I understand now this is a fantastic opportunity, this forum, the COLDA forum, and from the discussions at lunchtime, not only were we discussing Tanzania, but maybe Egypt for the next COLDA, but we need to think about the public health issues and benchmarking of policies, and I'm certainly going to concentrate on that in the next 22 minutes or so. And the title I've decided to use is this really a future issue for us in this forum for an African environment? These are my disclosures. There's a spectrum in the audience. There are no easy answers to this. The data is problematic. I have to acknowledge up front that there is a better expert in alcohol in the audience who may have shared some of his slides, but we're saving his voice for his tour de force later. And importantly, the slide on the picture shows you really our ambiguity about alcohol and the issues we have about alcohol. This is a slide from many, many years ago from Newcastle, Northumberland, very different to here, but there's no doubt the cultural issues we have about the usage of alcohol and our acceptance of alcohol and our patterns of usage of alcohol are really important. And reading around the subject for the African experience is something that is really not yet coming up to fruition and not really on the radar in the way it should be from a policy perspective. On the ground, I think you're seeing it, and I hope that we have time to have some discussion about that. You know all of this, but this is partly just to remind myself that there are significant health disparities in liver disease in sub-Saharan Africa. 11% of the world's population, 24% of the global disease burden, but we may talk about the accuracy of that, yet allocation of less than 1% of the global health spend on health and 3% of the global healthcare workforce, which is not very good compared to the rest of the world. And there are many, many barriers to healthcare, and you are much better aware of those than I am. There are disparities not only in that, but also in liver disease, and clearly, appropriately, the focus has been on viral-related diseases. But for the purposes of this talk, I really want to move you a little bit to think about alcohol as a potential contributor and really a growing issue for us that I think, for me, and I'm being provocative, is currently focused much more, should be focused on a policy environment than anywhere else. So you can see here the etiologies of hepatitis B, C, and alcohol. Liver disease reflects the broader disparities of healthcare and the socioeconomic disparities. And there are improvements, significant improvements, certainly in the care of viral hepatitis, but I want to talk about non-communicable diseases and other causes of liver disease as we are in this session. These are the nice pictures you can get when you look to see if at burden of disease and health disparities, and you're all aware of this, and you can see HIV, hepatitis B, and HCV. But actually, when you look at the literature, the data is very, very poor. It's good to get some modeling data. It's good to, and there's an expert on the chairing here, but actually the root data, when you look at sub-Saharan Africa with regard to liver disease per se, is very poor. This is an article, an opinion piece from 4 years ago, and really assessing that there is very little data that's accurate with regard to this part of the world and the issue of liver disease and the burden of cirrhosis. And that's a concern. How accurate is the data we're modeling on? Do we really understand what's going on? And really the WHO burden of disease type assessments, how much do they tell us and how accurate are they? I'm going to flavor in some of the slides from the very good recent EASL clinical practice guidelines. And again, they are very useful as a resource and they're available, so please go to them. But of course, they're not focused on this environment, and we really need to talk about Africa and the issues around alcohol in Africa. So to remind you, alcohol is pervasive. Alcohol-related morbidity and mortality is significant. Worldwide, 3.3 million deaths a year and significant disability-adjusted life years. 5.1% of the global burden of disease and injury is related to alcohol. It has an impact on over 200 diseases and types of injuries, and most deaths are attributable to cardiovascular diseases, injuries. There's a psychosocial, medico-legal aspect to alcohol dependency and alcohol use disorders. But of course, in this field, we're talking about liver disease, we're talking about cirrhosis, we're talking about HCC, and all of those issues. And of course, let us not forget the impact on women and the issues with fetal alcohol syndrome. So significant issues. So what do we know about alcohol consumption in sub-Saharan Africa versus the world? Again, some of these slides will not project well. And really, I want you to focus on the box, the red box that shows the world and the data from the sort of world adult consumption versus sub-Saharan Africa. And there's no doubt that Africa is a younger country compared to the rest of the world. There's no doubt that the data that we don't know, the unknown unknowns with regard to alcohol usage, is much higher than we in Africa compared to the rest of the world. And actually the pattern of drinking may be different, maybe more episodic, maybe more binge-like drinking. So in essence also, an issue is also illicit alcohol and fermented beverages that we really can't control, that are produced in different ways, that may have in themselves other additives and other potential risks for disease in and outside the liver. But really the concern I want to highlight to you is if this is the data and you have a predominantly young population, you're going to have a trajectory for various reasons that I'll highlight and be provocative about, that you may see alcohol becoming more and more of a cofactor and more of an issue in your globalization and urbanization ethos. Again, I'm sorry, but not that sorry, to really focus on the public health aspects, because I think that is what is interesting in the context of this audience and this forum. The data is conflicting around what is a safe alcohol limit. Light to moderate intake may, in some of the data, suggest a reduced risk of coronary disease. We know that alcohol is recognized as a carcinogen, but there's no threshold of consumption known for cancer risk. Binge drinking versus daily drinking, the Scandinavian versus the sort of Mediterranean pattern of drinking, for want of a better analogy, remains controversial. But there is no doubt that the cessation of drinking at any point reduces the risk of progression and the occurrence of complications. And that is why I think we need to go back to the policies that we put in place for populations that are really quite relevant. What about the risk of other diseases, and particularly communicable diseases, in the context of alcohol? Well, actually, there is quite a bit of data there. You know and I know that hepatitis B and hepatitis B transmission, significant issues in the context of sub-Saharan Africa. But we know that alcohol use as a cofactor is quite important. If you drink alcohol, you may have more risky behavior that might increase your risk of communicable diseases. And there's data to show that if with an increase in your blood alcohol concentration of 0.1, you have an increase in your likelihood of engaging in more risky behavior and putting yourself in a more optimal situation of acquiring a communicable disease, for want of a better way of phrasing that. What about the risk of alcohol and HCC? Again, I think COLDA needs to focus very much on the HCC issues for Africa, but there's no doubt that the 10-year cumulative incidence associated with hepatitis B is higher in those who report alcohol usage for those with HPV or alcohol alone. And you can see that, and there is data there. So as a cofactor, do we really understand the burden of disease that we're already seeing in Africa related to alcohol usage? And do we have accurate data? And actually, where are we at with regard to the policies? This slide is not going to project very well at all. I apologize. But in essence, this is one of a set of good papers from these authors who have modeled and looked at the policy issues. And they're suggesting that 6.4% of all deaths and 4.7% of all disability-adjusted life years in Africa in 2012 were related to alcohol. So alcohol is not a future problem. Alcohol is, in essence, a problem that is happening now, but really, do we have the policies and do we have the awareness to say this is something we should be thinking about? These are the same authors, and I thought this is a very good paper. I think this is one of the important slides of this talk. And this is a review looking at the harmful use of alcohol and titling it as a shadow across sub-Saharan Africa and in dire need of workable solutions. And they make a very compelling case to say that this is a neglected area, that there are not enough strategies and policies, that the African environment is actively being targeted by the industry, and there is an amalgamation of two of the large companies and a very clever focusing of alcohol branding and alcohol advertising to different groups, young people particularly. Alcohol usage is embedded in cultural activities. Of course it is in every environment, but it's seen in this environment perhaps more as an emblem of success, so something to be aspired to. There's the availability issue with illicit production and a lack of regulation and the shebeens, and that has its own risks. We know very clearly from very good data that pricing has a huge effect on the availability and usage. And pricing is an issue that has been in flux. And as I've highlighted already, 30% of the population, we don't have really any data with regard to their intake. So in 2010, the suggestion was that the yearly consumption was 6 liters of alcohol per capita, but this was seen as episodic, this was seen as an underrepresentation, and in an environment where up to 50% of the population may be abstaining, compared to, say, a Western population, it means those who are partaking alcohol are much more likely to be potentially drinking up to 20 liters per year of alcohol per capita. So it's what do we don't know, and actually what we do know suggests that we may have more alcohol in the system contributing to disease than we're recognizing at this moment in time. Has anything been done about this? Well, actually, Kenya and Rwanda in 2007 and the World Assembly actually were one of the initiators of the issues about alcohol. And from the regional WHO, there was a working group set up to address non-communicable diseases and an alcohol strategy around this. But nothing has really happened since 2010 when that has come out, and since then, everything has been pushed back into the dust. You can see quite reasonably that 50% of funding in 2000 to 2009 was actually focused much more on HIV and malaria, and I can understand that, and we all understand that. But we just need to be aware of the full gamut of liver diseases and policy issues that we have. And there's very little regulation of the alcohol industry. In a world where there's a drive to set up treaties and engagement in commercial activities, there may be some slippage with regard to the ability of governments to regulate alcohol and the alcohol companies. And lastly, and this is the same group, they provided an exercise looking at 46 countries, sub-Saharan African countries, looking at the policy framework that they have, and only 10 out of the 46 countries had any real semblance of a working alcohol policy to try and address these issues. So I think this is really the important slide, and really tells us that there needs to be some urgent engagement with regard to policies and the understanding of the liver disease that's associated with alcohol, plus all the other issues that comes with it. Let me show you some data. I've trawled the data to see what we can show you. So here is some random data. This is from Nigeria. This is a tertiary teaching hospital over 5 years, and you can see here the pattern of disease in hospitalized patients. So you may say over 5 years the numbers are not that impressive, but you can see here liver cancer is off the scale. There's a whole range of cirrhosis down to fulminant hepatic failure. Someone from King's, I'm interested in that. But what you can see here, when they look a little bit more carefully, is 50% of those patients admitted over that time period, a tertiary hospital, admissions, significant disease, so a very small sector of the whole pathway, but 50% of these patients had significant alcohol consumption driving their liver disease presentation. Also, it's fair to note that 49%, 50% also had hepatitis B. So this cofactor of driving the usage of this and the recognition of liver disease related to alcohol is something that in this environment we need to be more aware of. This again will not project very well, I apologize. This is from Uganda. And this is looking at an emergency department over a period of time, a large urban hospital, a cross-sectional study, again showing, assessing alcohol misuse using a cage questionnaire and assessing individuals as they came through the door. And as I recall, 20% had met the definition of an alcohol use disorder. It's an emergency department setting, but that is a westernized type environment of alcohol utilization and misuse that you're seeing in a Ugandan environment. And this data is, again, from 5 years ago, so it's likely to be out of date and likely to be an underestimate. So this is not a picture of Mark Thirst without his goatee beard. He can get me back afterwards, but actually Mark is an expert on this. But my slide is, alcohol may be the price of globalization. It's to do with the demographics of the population. It's to do with rapid urbanization. It's the success, perhaps, of economic development. You have increased availability. There's no doubt there's a corporate targeting in this part of the world with regard to alcohol. The alcohol flavored malt drinks for certain populations, the targeting of a younger group as they come through, and the advertisements around that. There is a weak policy structure. I hope I've demonstrated that to you, addressing price, availability, marketing, and even drink driving policies. And of course, I've highlighted that trade agreements may dilute the ability of health policy enablers to make these things really work. So there are significant issues here, but the intent simplicity for me is that there needs to be better public health and policy work in an African setting around alcohol. Again, we need to highlight Mark's great work with regard to this, and yes, it's the E stands for European, but this is a really up-to-date, really good, tight view of the way to manage alcoholic liver disease and the issues around it with an expert representative body. And it gives us grade recommendations, which I think are useful, and these are guidelines, but I think EASL is really now the premier organization with regard to its clinical practice guidelines. So I've speckled a few of these slides through as summaries, and just going to talk a little bit about the practical management of alcohol usage and alcoholic liver disease. Again, I make no apology for highlighting the public health issues associated with alcohol, and again, the issues around excess alcohol consumption and the addressing of this associated with price-based policies and regulation of availability. The advertising of alcohol, this is a pervasive societal issue, that actually it's not very expensive to do a caged questionnaire or to talk about this as a health intervention when you're testing for hepatitis B or in a non-specialist hospital setting. And that in any setting, primary healthcare providers should be taking this on as part of their work as a preventative environment. And we would hope that we would be able to offer multidisciplinary input. But let's recognize and delineate the size of the problem in any setting. And this applies to London as well as anywhere else in the world. I think, again, just like the hepatitis B CPG, which I changed the nomenclature and really wanted to change the tenor, I like this aspect that comes out of these guidelines. And I had to change the slides because the term alcoholic is somewhat stigmatizing. It can mean many things for many people, but I very much like the current term, or the term that's recommended, as alcohol use disorder rather than alcoholic. And I think we need to start to move to this sort of terminology, and likewise you can see the other terminologies associated with alcohol: steatohepatitis, fibrosis, and alcoholic hepatitis, which is clearly an area of active research at this moment in time. Does it matter what you drink? These are the things that people tell you. Again, there are some old slides that I'm going to put in, mostly borrowed from Mark, and this is demonstrating that perhaps beer drinkers may have more in the way of mortality, but again, we need to be a bit smarter and suggest that those people who drink beer compared to their French Chateauneuf du Pape or their Franschhoek or Stellenbosch wines may have a different kind of diet and therefore a different kind of comorbidity profile to those who may enjoy their beer. I'm looking at you, Mark. Importantly, and we do it very badly, and I work in a large teaching hospital, we think, that's very famous for not managing its finances very well and being the worst hospital in England at this moment in time. But even in that sort of environment, we're very bad at the recognition and the assessment of alcohol use disorders. And there are very simple screening tests that we should be using. They're not requiring point-of-care testing, they're not requiring a drone, but actually we should be using them much more, and we should be much more comprehensive and aware that they can highlight not only to the providers but also to that individual that they may be drinking to excess, and that lifestyle changes need to be thought about. So how might we manage the diagnostic tests, with the availability of diagnostic tests in the context of alcoholic liver disease? These are the standard things. We've talked about Fibroscan. Of course, we need to rule out additional causes of liver disease, and Mark is going to talk about another driver of liver disease, which is clearly, again, the price of globalization and urbanization, but that is often now a cofactor in those patients with alcoholic liver disease. And I'm not going to talk about transplantation. I'm not going to talk about the management of end-stage liver disease because I think we should be focusing on the policies and the recognition as in this forum. These are the diagnostic, the indirect markers of alcohol consumption, GGT, AST, ALT, MCV. You're all aware of these. These may give us a hint, but nothing supplants clinical history and an accurate alcohol history. And these can give us a hint, but they're not adequate in themselves to give us a firm diagnosis of alcohol consumption. And we can use, depending on our ability and our resources, other tests, and I become much more a fan of non-invasive serum tests as opposed to even Fibroscan, and we should be using these to assess all causes of liver disease, but certainly these may help us in the context of the disease of fibrosis associated with alcohol usage. And lastly, highlighting for you Fibroscan. Everyone's very excited about Fibroscan. I think in the context of alcoholic liver disease, you've got to be very cognizant of inflammation and the hepatitis component of, say, alcoholic hepatitis. And my personal view is I'm not so sure how useful Fibroscan can be in the acute setting of someone presenting with jaundice and, say, alcoholic-related liver disease. And that moves me through to talk a little bit about liver biopsy. If you have the ability to do that, I think it can provide very helpful information. And certainly for us in the context of alcoholic steatohepatitis, I think that is an important disease to identify early. And of course, there is a spectrum of disorders that you see. And this is a slide just demonstrating those for you and showing the various different manifestations you may see. Diagnostic tests, 90% of heavy drinkers will have steatosis. Again, a little bit like the sort of NASH-NAFLD story. It's really when you're getting the fibrosis and the hepatitis associated with steatosis that you are starting to pull yourself out to somebody who may get underlying liver scarring and liver fibrosis. And there clearly is a lot of overlap, and I'm hoping that Mark might allude to BASH, which I think is kind of an interesting diagnosis and something that we will be seeing and we are seeing more of. And again, talking about alcoholic hepatitis, which again we have not really focused on, and we felt it's been a sort of therapeutic desert. We really need to understand the utility of the different scoring systems, the MADRE score, which again has been around for a long time and tells us which patients will benefit from steroids, to the Glasgow alcoholic hepatitis score, and the Lille score, which gives us a sense of the responsiveness to steroids quite quickly. Because in the context of alcoholic hepatitis, I think the real risk is infection that kills patients. And again, there are individuals in the audience who really know what they're talking about here, and for the sake of time, I'm going to move through. What's the general management? And again, it's very simple. It's abstinence and nutrition and supplementing those things that are deficient, and really good clinical management, optimal clinical management, and managing fluid status. And again, I put this slide in specifically, again, 1993. This is a catabolic state. The benefit of nutrition, enteral nutrition, to me, is something that is still important and is recognized in the EASL CPG guidelines. And lastly, we have to, because we have to, the STOPPER study, a very, very good study that talked about steroids versus pentoxifylline for alcoholic hepatitis, ran in England and the UK. And again, I would urge, from what I've listened to today and in other meetings, that there's an urgent need to reflect the African experience in the publication and in the trials, whether it's hepatitis B, hepatitis C, still, but we really need to know that data. It's this data vacuum that I feel. But a really well done study comparing pentoxifylline and prednisolone. Very bad logo. Mark is really bad at doing his logos. But you can see here, pentoxifylline, no benefit, and a benefit for steroids in the context of these patients, and a really well-conducted study that has re-energized the field with regard to newer agents. So here is the sort of cartoon to manage alcoholic hepatitis, the clinical diagnosis, the treatment of alcohol dependence, the consideration of liver biopsy, the extensive screening to exclude infection, and then a decision about steroids, a decision at day 7, and really being vigilant for infection in the context of those patients. And also, I would say, although not so much for this audience, and I was asked about it in the coffee break, we should be thinking about transplantation for these patients if that is a potential option that we can offer. Lastly, managing alcohol-related fibrosis, got to be aware of the comorbid conditions. For those colleagues who've done a fantastic job on a national perspective with regard to hepatitis C, I would say that is phenomenal and impressive, but how do you manage post-SVR health? You take someone through a course of DAA therapy, how do you manage their NASH, NAFLD, obesity, other issues? We know that there is a huge prevalence of diabetes in Egypt, so we've got to maintain liver health in any setting. So it's always about the comorbid conditions, and I hope I've shown you that in this African setting. And again, abstinence, nutritional support, and if they are cirrhotic, managing those patients for the prophylaxis of secondary complications. Second to last slide, worth emphasizing, not expensive, abstinence really does make a difference. This is from 1968, Klatskin, and you can see the difference between the cirrhosis patients and decompensated cirrhosis patients for those who achieved abstinence and those who didn't. So again, lifestyle, policy, awareness, all of those things are really important in this setting. And then I'll finish on this. Do we know the data? Do we have the data? Alcohol is a multifaceted issue. There are other issues that are in front of us in the context of the African health situation. Those are important, but alcohol, I think, is an issue for this region now, and I think is going to be an increasing issue for you in the future. Thank you for your attention.